process by which the urinary bladder empties when it becomes filled. It involves two main steps. First, the bladder fills progressively until the tension in its walls rises above a threshold level. This elicits the second step, which is a nervous reflex called the Micturition reflex that empties the bladder, or if this fails, at least causes a conscious desire to urinate. Although the micturition reflex is an autonomic spinal cord reflex, it can also be inhibited or facilitated by centers in the cerebral cortex or the brainstem. So, coming to the physiological anatomy of the bladder, you can see the bladder here. Okay. So, it is a smooth muscle chamber composed of two main parts: the body, which is a major part of the bladder in which the urine is collected, and the neck, which is a funnel-shaped extension of the body passing inferiorly and anteriorly into the urogenital triangle and connecting with the urethra. The lower part of the bladder neck is also called the posterior urethra because of its relation to the urethra. The smooth muscle of the bladder is called the detersor muscle, and its muscle fibers extend in all directions. See, this is the detersor muscle. Okay, so when contracted, the detersor muscle can increase the pressure in the bladder to 40 to 60 mm of Hg. Thus, contraction of the detersor muscle is a major step in emptying the bladder. Smooth muscle cells of the detersor muscle fuse with one another so that low resistance electrical pathways exist from one muscle cell to the other. Therefore, an action potential can spread throughout the detersor muscle from one muscle cell to the next to cause contraction of the entire bladder at once. On the posterior wall of the bladder, lying immediately above the bladder neck, is a small triangular area called the trigone, as you can see here. So the trigone, the upper angles are formed by the entry points of both the ureters. Okay. So the trigone can be identified by the fact that it is mucosa, the inner lining of the bladder. Its mucosa is smooth, contrast to the remaining bladder mucosa, which is folded to form rugae. At the lowermost apex of the trigone, the bladder neck opens into the posterior urethra, and the two ureters enter the bladder at the uppermost angles of the trigone. Each ureter, as it enters the bladder, courses obliquely through the detersor muscle and then passes another 1 to 2 centimeters beneath the bladder mucosa before emptying into the bladder. The bladder neck or the posterior urethra is 2 to 3 centimeters long, and its wall is composed of detersor muscle interlaced with a large amount of elastic tissue. The muscle in this area is called the internal sphincter. Its natural tone normally keeps the bladder, neck, and posterior urethra empty of urine and therefore prevents emptying of the bladder until the pressure in the main part of the bladder rises above a critical threshold. Beyond the posterior urethra, the urethra passes through the urogenital diaphragm, which contains a layer of muscle called the external sphincter of the bladder. This muscle is a voluntary skeletal muscle in contrast to the muscle of the bladder body and the bladder neck, which is entirely smooth muscle. Okay, the external sphincter is under voluntary control of the nervous system and can be used to consciously prevent urination even when involuntary controls are attempting to empty the bladder. The principal nerve supply of the bladder is by way of the pelvic nerves, which connect the spinal cord through the sacral plexus, mainly to the S2, S3, S4 segments. Okay, so you can see the sacral nerves. Okay, coursing through the pelvic nerves are both sensory nerve fibers and motor nerve fibers. The sensory fibers detect the degree of stretch in the bladder wall. Stretch signals from the posterior urethra are especially strong, that is, the neck are especially strong, and are mainly responsible for initiating the reflexes that cause bladder emptying. The motor nerves transmitted in the pelvic nerves are parasympathetic fibers. These fibers terminate on ganglion cells located in the wall of the bladder. Short postganglionic nerves then innervate the detersor muscle. In addition to the pelvic nerves, two other types of innervation are important in bladder function. Most important are the skeletal motor fibers transmitted through the pudendal nerve to the external bladder sphincter. These fibers are somatic nerve fibers that innervate and control the voluntary skeletal muscle of the sphincter. Also, the bladder receives sympathetic innervation from the sympathetic chain through the hypogastric nerves connecting mainly with the L2 segment of the spinal cord. These sympathetic fibers stimulate mainly the blood vessels and have little to do with bladder contraction. Some sensory nerve fibers also pass by way of the sympathetic nerves and may be important in the sensation of fullness and in some instances pain. Okay, so you can see here from the L2 segment passing through the sympathetic chain, you have your sympathetic innervation of the bladder, which has mainly to do with the blood vessels of the bladder. And then parasympathetics and pudendal nerves, S2, S3, L4, they are the root values. Pudendal nerve, it controls the skeletal muscles of the bladder. Okay, parasympathetics mainly control your smooth muscles of the bladder and cause them to contract. Coming to transport of urine from the kidney through the ureters and into the bladder. Urine that is expelled from the bladder has essentially the same composition as fluid flowing out of the collecting ducts. Therefore, there are no significant changes in the composition of urine as it flows through the renal calyces and ureters into the bladder. Urine flowing from the collecting ducts into the renal calyces stretches the calyces and increases their inherent pacemaker activity, which in turn initiates peristaltic contractions that spread to the renal pelvis and then downward along the length of the ureter, thereby forcing the urine from the renal pelvis towards the bladder. In adults, the ureters are normally 10 inches long. The walls of the ureters contain smooth muscle and are innervated by both sympathetic and parasympathetic nerves, as well as by an intramural plexus of neurons and nerve fibers that extends along the entire length of the ureters. As with other visceral smooth muscle, peristaltic contractions in the ureter are enhanced by parasympathetic stimulation and inhibited by sympathetic stimulation. These peristaltic contractions are initiated by the intrinsic pacemaker activity of the renal calyces when they are stretched because of the urine that fills them. The ureters enter the bladder through the detersor muscle in the trigone region of the bladder as shown. Okay, they enter like this. And then the ureters normally course obliquely for several centimeters through the bladder wall. The normal tone of the detersor muscle in the bladder wall tends to compress the ureter, thereby preventing backflow reflux of the urine from the bladder when pressure builds up in the bladder during micturition or bladder compression. Each peristaltic wave along the ureter increases the pressure within the ureter so that the region passing through the bladder wall opens and allows urine to flow into the bladder. In some people, the distance that the ureter courses through the bladder wall is less than normal, and thus contraction of the bladder during micturition does not always lead to complete occlusion of the ureter. As a result, some of the urine in the bladder is propelled backward into the ureter, a condition called vesico-ureteral reflux. Such reflux can lead to enlargement of ureters and, if severe, can increase the pressure in the renal calyces and structures of the renal medulla, causing damage to these regions. Coming to pain sensation in the ureters and the ureterorenal reflex. The ureters are well supplied with pain nerve fibers. When a ureter becomes blocked by a ureteral stone, for example, intense reflex constriction occurs, which is associated with severe pain. Also, the pain impulses cause a sympathetic reflex back to the kidney to constrict the renal arterioles, thereby decreasing urine output from that kidney. This effect is called the ureterorenal reflex, and it is important for preventing excess flow of fluid into the pelvis of a kidney with a blocked ureter. Coming to the filling of the bladder and bladder wall tone and the systematogram, this figure, it shows the approximate changes in intravesicular pressure as the bladder fills with urine. When there is no urine in the bladder, the intravesicular pressure is about 0. But by the time 30 to 50 ml of urine has collected, the pressure rises to 5 to 10 centimeters of water. Okay? Additional urine, 200 to 300 ml, can collect with only a small rise in pressure. Okay? This constant level of pressure is caused by the intrinsic tone of the bladder wall itself. Beyond 300 to 400 ml, the collection of more urine in the bladder causes the pressure to rise rapidly beyond 300 to 400 ml. Superimposed on the tonic pressure changes during filling of the bladder are periodic acute increases in pressure that last from a few seconds to more than a minute. The pressure peaks may rise only a few centimeters of water or may rise to more than 100 centimeters of water. These pressure peaks are called the Micturition waves in the systematogram and are caused by the Micturition reflex. Okay, coming again to the Micturition reflex, we can see in this figure that as the bladder fills, many superimposed Micturition contractions begin to appear as shown by the dashed spikes here. They are the result of a stretch reflex initiated by the sensory stretch receptors in the bladder wall, especially by the receptors in the posterior urethra, when this area begins to fill with urine at the higher bladder pressures. Sensory signals from the bladder stretch receptors are conducted to the sacral segments of the cord through the pelvic nerves and then reflexively back again to the bladder through the parasympathetic nerve fibers by the way of these same nerves. When the bladder is only partially filled, these Micturition contractions usually relax spontaneously after a fraction of a minute, and the detersor muscles stop contracting and pressure falls back to the baseline. As the bladder continues to fill, the Micturition reflexes become more frequent and cause greater contractions of the detersor muscle. Once a Micturition reflex begins, it is self-regenerative. That is, initial contraction of the bladder activates the stretch receptors to cause a greater increase in sensory impulses from the bladder and posterior urethra, which further causes a further increase in reflex contraction of the bladder. Thus, the cycle is repeated again and again until the bladder has reached a strong degree of contraction. Then, after a few seconds to more than a minute, the self-regenerative reflex begins to fatigue, and the regenerative cycle of the Micturition reflex ceases, permitting the bladder to relax. Thus, the micturition reflex is a single complete cycle of progressive and rapid increase of pressure, period of sustained pressure, and then return of pressure to the basal tone of the bladder. So once a micturition reflex has occurred but has not succeeded in emptying the bladder, the nervous elements of this reflex usually remain in an inhibited state for a few minutes to 1 hour or more before another micturition reflex occurs. As the bladder becomes more and more filled, micturition reflexes occur more and more often and more powerfully. Once the micturition reflex becomes powerful enough, it causes another reflex which passes through the pudendal nerves to the external sphincter to inhibit it. If this inhibition is more potent in the brain than in the voluntary constrictor signals to the external sphincter, urination will occur. If not, urination will not occur until the bladder fills further and the micturition reflex becomes more powerful. Coming to facilitation or inhibition of the micturition by the brain, micturition reflex is an autonomic spinal cord reflex, but it can be inhibited or facilitated by centers in the brain. These centers include strong facilitative and inhibitory centers in the brainstem, located mainly in the pons, and several centers located in the cerebral cortex, such as the paracentral lobule, that are mainly inhibitory but can become excitatory. Okay, the micturition reflex is the basic cause of micturition, but the higher centers normally exert a final control of micturition as follows. The higher centers keep the micturition reflex partly inhibited, except when it is desired. The higher centers can prevent micturition even if the micturition reflex occurs by tonic contraction of the external bladder sphincter voluntarily until a convenient time presents itself. When it is time to urinate, the cortical centers can facilitate the sacral micturition centers to help initiate a micturition reflex and at the same time inhibit the external urinary sphincter so that urination can occur. Voluntary urination is usually initiated in the following way. First, a person voluntarily contracts his or her abdominal muscles, which then increases the pressure in the bladder and allows extra urine to enter the bladder neck and posterior urethra under pressure, thus stretching their walls. This action stimulates the stretch receptors, which excites the micturition reflex and simultaneously inhibits the external urethral sphincter. Ordinarily, all the urine will be emptied with rarely more than 5 to 10 ml left in the bladder. Coming to abnormalities of micturition, atonic bladder and the incontinence caused by destruction of sensory nerve fibers. Micturition reflex contraction cannot occur if the sensory nerve fibers from the bladder to the spinal cord are destroyed, thereby preventing transmission of stretch signals from the bladder. When this happens, a person loses bladder control despite intact efferent fibers from the cord to the bladder and despite intact neurogenic connections within the brain. So instead of emptying periodically, the bladder fills to capacity and overflows a few drops at a time through the urethra. This occurrence is called overflow incontinence. A common cause of atonic bladder is crush injury to the sacral region of the spinal cord. Certain diseases also cause damage to the dorsal root nerve fibers that enter the spinal cord. For example, syphilis can cause constrictive fibrosis around the dorsal root nerve fibers, destroying them. This condition is called tabes dorsalis and the resulting bladder condition is called tabetic bladder. Coming to automatic bladder, caused by spinal cord damage above the sacral region. If the spinal cord is damaged above the sacral region but the sacral cord segments are still intact, the typical micturition reflexes still occur. However, they are no longer controlled by the brain. During the first few days to several weeks after the damage to the cord has occurred, the micturition reflexes are suppressed because of the state of spinal shock caused by the sudden loss of facilitative impulses from the brainstem and cerebrum. However, if the bladder is emptied periodically by catheterization to prevent bladder injury caused by overstretching of the bladder, the excitability of the micturition reflex gradually increases until typical micturition reflexes return. Then periodic but unannounced bladder emptying occurs. Some patients can still control urination in this condition by stimulating the skin by scratching or tickling in the genital region, which sometimes elicits a micturition reflex. Uninhibited neurogenic bladder caused by a lack of inhibitory signals from the brain. Another abnormality of micturition is the so-called uninhibited neurogenic bladder, which results in frequent and relatively uncontrolled micturition. This condition derives from partial damage in the spinal cord or brainstem that interrupts most of the inhibitory signals. Therefore, facilitative impulses passing continually down the cord keep the sacral centers so excitable that even a small quantity of urine elicits an uncontrollable micturition reflex, thereby promoting frequent urination.